Welcome. I'm Elizabeth Morera, the Deputy Director of Administration for the City of Pawtucket, Rhode Island, and Volunteer Director of Operations for Project Health CV Incorporated. I previously served as the City of Pawtucket's first Public Health and Equity Director, where I led the COVID-19 response and provided multilingual support and resources to Rhode Island's hardest hit communities. I'm also a proud board member of Primary Care for All Americans. On behalf of the board, I'm pleased to welcome you to tonight's Teach in Learn in Zoom session. Thank you for joining us this evening. With over 1,600 people from 40 states, the District of Columbia, and 350 zip codes, we are reminded of the incredible momentum we are building together to provide primary care to every American neighborhood and community. Thank you for your dedication and commitment to expanding access to primary care across the country. Now, it's my great pleasure to introduce our moderator for this evening, Patty Armstrong, and to extend my sincere thanks to all the presenters for tonight's event. I'd like to thank the Primary Care for All American Zoom committee, as well as John Wright, Patty Armstrong, Liv Verity for organizing the event. Take it away, Patty.
Hi, everyone. I'm Patty Armstrong. I've been a longtime member of PC4AA. In my day job, I am the Resource Development Director for United Way of Greater Fall River in Massachusetts. But I want to start by thanking you all for being here tonight. By joining us, you are helping to build a movement, one that focuses on providing health care to people in every neighborhood and community. Primary care for all Americans. Please take a minute, add your name into the chat. Just a quick reminder, we don't use professional titles here. This space is about working together and valuing the ideas and commitments that will drive this movement forward. Right now, it is my great pleasure to introduce our keynote speaker, Dave Chase. Dave Chase is a national leader in healthcare transformation and the creator of the community-owned health plan model. He is the founder of Health Rosetta, where he has helped thousands of employers improve care while reducing healthcare costs by 20 to 50%, impacting more than 5 million Americans. Dave previously founded Microsoft's 30 billion healthcare ecosystem and is the author of several best-selling books on healthcare reform. His work has reached millions through media and TED Talks. He is the recipient of the World Health Care Congress Lifetime Achievement Award for Health Benefits Innovation. Take it away, Dave.
Thanks so much. Appreciate the kind introduction. And I am going to dive into a presentation. I shared a link to it, which it's a Google slide deck with the team here. So I'm going to go through some slides, relatively quickly. I'm happy to have them shared. There's also slides at the back that I'm not going to get into. But I just want to dive right in. And the overarching theme is every one of these successes is built on a foundation of primary care. And so in some cases, I'm not going to go into all the primary care details. I've got a book coming out that's going to launch at our event called Rosetta Fest. So it'll publish into July. It's called Relocalizing Health. And then the subtitle is Taking Back Healthcare, Rebuilding Communities. And I have written some short stories on these particular stories here that will shed more light if you want that. And you'd get a sneak peek of what's going to be in the book. So I believe very strongly that we have a fork in the road, and the sooner we take it, the better. And really what struck me as I was creating this presentation and getting to know Michael Fine over the years is some of you may be familiar with his book called On Medicine as Colonialism. And I think that's a really important framing. We all have an opportunity to reclaim health sovereignty in our communities. And these are three communities that absolutely did that. And so I'm going to start with the Alaska Native people's story with the South Central Foundation. in Alaska, and they have a care model called the NUCA system of care. Uh, I think they can probably claim the best primary care in America. What they've done there is just outstanding, not only with the core primary care, but the way they've incorporated behavioral health consultants and what they call behaviorists. And I will reemphasize this point, but I can guarantee you nobody in North America has a bigger challenge on their hands in terms of they serve 70,000 people over the area the size of Sweden, going out to the Aleutian chain. And there's places that don't have a medical assistant. And they very much have solved primary care in a big way, very creatively. And so there's more in my story, and I'm going to talk some about it. But the important thing was initially was they started making some steps that were particularly enabled by the Indian Self-Determination Act, where Native American, Alaska Native peoples could take care of their system. And as one of their board members says, it isn't who pays for it, it's about who cares. And if you look at their story, you could use it as an excuse for or an argument for or against single payer that really misses the point. It's the governance and who cares. And they've really put incredible thought and diligence into how they've engaged with their community and how they govern it. Before they took back control, they had as probably the worst performing, model in the world. Well, in the US, some of the worst in the world, really high rates of TB. And, if you're going to go into, they basically had no primary care to speak of. Primary care was the ER, and you're going to basically bank on 6 hours of waiting to get in there. And so, very significant challenge. It looks like their design was done by some, East German architects. It was not a welcoming environment, and very few Alaska Native peoples were on the staff. But then they did take it over, did a complete redesign. They did 6 months of listening to the community, and they really blended the best of modern medicine, melding it with their native values and the wisdom of their elders. And they pretty much banned the word patients. Customer owner is the term that they use. They're even more vociferous about not using terms like compliance, except if it refers to providers complying. They very much believe that's a particularly problematic framework and mindset and term with patients or customer owners. And they really take this no excuses model. There's an island that they've got a village and there's not a medical assistant, but there's a need for medications. They figured out a bulletproof pharmaceutical vending machine, that can be remotely controlled and things like that. And the results are really impressive. They were typically bottom 5% on various HEDIS scores. In most realms, they're in the 90th percentile, certainly in the 75th percentile. I think maybe there's two measures that they haven't achieved that, and they've sustained this now over a couple of decades. And it's led to all kinds of additional benefits where now more than half of the staff are Alaska Native people. And then they had a partnership with a local university to address the workforce pipeline and really have just imbued an incredible benefit to their community. And they didn't just take over the system and do it unchanged. As I said, they did this listening tour, and they really and continue to listen to the community. And I was just speaking to their CEO last week, and she was sharing stories of how they wanted to get this community on one of the islands, have the women have their mammograms, and they were like wanting it to have in October because they thought, well, that's after the moose hunting season. They're like, nope, that is not. We are busy, doing all the post hunt preservation, we're not coming then. We want to come in February. And they figured it out, right? These are the types of things that they are incredibly responsive to the particular unique challenges. And there's many more. And I've got a podcast called Relocalizing Health. And so if you want that story, you'll hear more about it soon. But uh, what does local control mean? It's not a local governing board that answers to higher authority. It really is ownership to all those who seek care. And, they shared another story of in one of these villages, they had a grant to build out a duplex that would help get some staff in that area. Um, and the community said, no, we want them to be in this we want you to put that money into this dilapidated house, which was basically where teens were going and doing some not great stuff. And they let them know, hey, this might hurt recruiting. We'll do what we can, but it's ultimately your decision. They said, do it. We want people who are, um, you know, hardy enough to deal with it. And so that's the type of approach they take. And as I mentioned, they have people scattered all over. By the end of January 2021, they had the COVID vaccine available to every member of their community. And this were people, going in Zodiacs, which are like inflatable boats, to get to some of these places we couldn't even fly in. They just took a no excuses approach. And it's always super impressive. And you can see some of the pictures of what they do and how they reach out to their community. It's actually now 70,000, so I should update this. But again, wonderful story. Now I'm going to switch to another story. And again, rooted around primary care. They're in the most price gouging state in the union, Florida. 40% of the most expensive hospitals are in Florida. And it started out with the Rosen Hotel Company as an employer, initially 500 employees, now 5,000, really built primary care from the ground up. Initially in just a old accounting office. Now it's got a full-blown team. You got docs, nurses, dietitians, social workers, PTs, chiros. I'm leaving out some, and they just built it brick by brick. And what they did with their health plan, which I'm not going to go into great detail here, has allowed them to save cumulatively $570 million benchmarked against other employers. They've now done this for 30 years. And this is this virtuous cycle that it's not that day one they're spending 55% less per capita than others. It's just everybody else let the costs go up like this and they managed it and pretty much grew at regular inflation. And so they just look smarter every year. And so that is the approach that they took. And they also engaged with the community, but it was a challenged community. And Tangelo Park, which is this nearby community, used to be where tourists, if they wanted drugs, when they go to Orlando, that might be where they would go. And the principal at the elementary school would get there early to pick up needles and other drug paraphernalia. But it was a community that had pride, but had low college achievement. And that's where they started in terms of their chance of graduating, which was 9% of graduating from college, given the income level. But the community was open when Mr. Rosen said he wanted to support the community, going beyond his own employees, where they have this world-class health benefit plan, to where they would use some of what we call the Health Rosetta dividend to invest in kids in education. It's fully fund daycare, pre-K, after-school programs, now hundreds of college scholarships. And the results have been very dramatic in terms of achievement. If you graduate from, out of this elementary school, you complete high school, you're going to get college education 100% paid for. You'll have exactly $0 debt. And they also do education of parents as well. So really a wonderful approach. As MLK's daughter talks about, this is really a program that wraps its arms around the community. It started in this incredible primary care foundation, but has expanded from there tremendously. And you can see in some years they have 100% college achievement. Our high school graduation, and it was very low when they took over. So it's had this incredible effect. You now have kids that were in this initial program who are now parents of kids in this program. It's been around that long. And so this is a type of thing that really is restoring the American dream. And you now see they're having college achievement above the highest quartile income communities. And it's been an incredible impact on crime as well, down nearly 80%, and just continues to reap dividends. And you can see that they are graduating all these graduates debt-free versus what you see a typical bachelor's degree recipient in terms of what their the rate of student loan debt. And the return on investment has been phenomenal in terms of societal impact and what this means in terms of lifetime earnings. There's been some studies around that. So really a terrific impact. I did a TED Talk about them nearly 10 years ago. And then they've in many ways became the template for what we did with Help Rosetta. Said, okay, what they did is great, but they did an incredible amount of work relative to the typical employer. Results were up here too. So our work has really been about how do we make it easy to do what Rosa did. And now, fortunately, we have thousands of successes in, small employers, large employers, union, non-union, rural, urban, public, private. We haven't found a place where this can't be done with the right people stepping up. And then that model in Tangelo Park went to Paramore, which is about 5 times their size. I heard they just adopted another community 5 times their a third community. So it continues to reap dividends for that community. The first of these community health plans to grow out of Health Rosetta, really inspired by what Rose and Anuka was doing. In fact, I'm going to mention Bryce Heimbach. He went to one of the Nuka training sessions that they have in the summer. There's a virtual session going on right now. So this was really initiated by the employers. And if you look at the dynamic in Ohio, it was kind of a stereotypical um, Midwest manufacturing company that's frankly been on a losing streak for the last 20, 30 years. And they had very significant challenges in terms of optimal health and different barriers. Many of the youth are living in low income households and, have a spend disproportionate amount of their monthly income on housing. 60% of the students are on free or reduced lunch. Again, low achievement as far as bachelor's degrees. So yet again, another very challenged community. Also a medical desert. Um, they have, I think, 1/3 the level of docs in their community. There were no independent primary care at all. But they didn't let that stop them. They did, and I can get into some of that if you want. But Bryce Heimbach, he's one of these people we train on these approaches, learned how to do it, stepped in. And here's the key point I want you to take away from, or one of the key points from this is it started with a single employer with 38 employees. 38 employees. That is not Walmart. This is a misnomer. You've got to start huge. But you look at this growth, they went from 38 to 500 to 1,300 to 3,600 to over 5,000, now tens of thousands. And it's expanded beyond their community. So it can start incredibly modestly. And any one of the reasons why we are focused on employers, it's the only area of permissionless innovation in healthcare. So you're a nonprofit, you're a public sector entity, you're a cooperative, you're a healthcare provider, you're an employer too. You can do this stuff today. It's on you if you're not, because we now have so many successes. And so I can't emphasize enough, and I'm doing my best to walk the talk, getting one of these going in my own community. Finally, I have direct primary care in my community, single hospital town. And, I'm going to public comment sessions talking about primary care for all Americans. And so engaging with my community. So I'm trying to do that in my own hometown as well. And if you look at what they have as far as the health plan, again, an exceptional primary care plan, even without any DPC docs in their community, no independent docs, They just talked to a doc that lived an hour away and said, "Hey, would you come 2 or 3 days a week? We've got a place for you to do it." Sure. And then now I think there's 3 or 4 DPC practices. Their concierge nurse navigator model is incredible. Independent community pharmacy, again, remove barriers to great care. And this was in an environment where there's a 900-pound gorilla health system that's basically price gouges during health hurricanes, aka hospitalizations. And so they just worked around them. And now that organization has come to the table because they're worried. A lot of volume has been moved away from them because most Americans are willing to drive 45 minutes to 2 hours to get world-class health care for free. And once they know it's high quality care, they will do that. And one of those places was a surgery center that was, depending where you were, 45 minutes to 2 hours away. And they now have opened a clinic. So they're starting to address the medical desert. And it's really impacting things in their community and cutting down on the drive times. But they had that. And from an economic development standpoint, this is way better than any tax break you could use to attract or retain a company. Uh, I like to remind people that every community has a river of healthcare money flowing through it. The source of that river is the pocketbooks of everybody in that community. It should work like a water cycle, but instead we have these giant corporate pipelines that extract that river of healthcare money to distant corporate headquarters and to Wall Street. And so what these communities are doing is they're cutting off those pipelines, and then rather than being left in drought by the big systems, they're able to recycle this in their community. And so that's what's happening there. The Health Rosetta dividends are, just, getting rolling. The eighth poorest school district was basically saved by this plan. That's a whole other story I can get into. Happy to share that. They were down to a couple $100,000 in their health plan reserves. Now this is only a district of about 300 staff. Now it's like 7 million. They're like, oh, what do we do with all this extra money? Do we, put it into healthy food or, whatever. People are adding back dependent coverage, which used to be a normal thing. These are the types of things that are happening with public and private sector employers here. And this is my favorite quote from Buckminster Fuller. You never change things by fighting the existing reality. Change something, build a new model that makes the existing model obsolete. I always say, we didn't get these guys by tweaking landlines and rotary phones, right? You always have to do a reset. That's what's happening. It can happen faster than you think. This was Easter morning, 1900. One car. 13 years later, where are the horses? So things can change rather rapidly. And so I love this quote by St. Catherine of Siena, out of darkness is born the light. I think we have plenty of darkness in our world, in our country right now. But we have time for change and really believe in that. And so I have, again, given the link to this deck to the Primary Care for All Americans team, happy to share it. But I'm going to stop sharing and happy to get the more stink eye hardcore questions, the better. So bring it on. And we don't have all the answers, but we've managed to succeed in some ways that have not been done before. And so we've learned quite a lot. We have lots of broken teeth and black eyes and skin knees along the way. But it's been very rewarding.
I love that, Dave. Thank you so much for sharing. And as he's already said, we will be taking questions. I see Margaret's already in there with a question, so we'll be over to you soon, Margaret. But we do want to accept them. If you have something you want to share, we'd love to hear from you. I do have some questions to get us started, and then I'm coming over to you pretty soon, Margaret. All right. So we don't have, I believe and many of the callers know about our local or state work groups that we've been developing. And a lot of them or none of them have benefit advisors that are part of that group. How can we connect best to those individuals?
Yes. So if you go to healthrosetta.org/map, assuming that that page is still working, they're plotted out on a map. There's also directory.healthrosetta.org. We're just doing some updates, or there could be some little glitches in that. I literally heard some stuff going on today. And so there's folks scattered around the country. There's a few states where we don't have anybody based, but there's folks nearby that cover those states. And you know, there is the bell curve of how advanced people are on this. As my co-founder says, church is for sinners. So we have people who've just come from the old world and are just learning this, but generally are very aligned, want to do something, and there's some incredible folks in there. We actually, interesting, we never intended this, but we have about a dozen clinicians, mostly physicians, and the physicians are mostly primary care. And candidly, they have been frustrated, where maybe they're a DPC doc and they have some businesses that they provide, or they want to provide their services to, and then um, gets brought up with the benefits broker that's status quo, and they're like, no, you can't do that, or it won't work here, or whatever lame excuse they have, and they'll get cut off at the knees, and so breaking news, it's a little harder to get through medical school than to become a benefits broker, and so some of them just said, screw it, I'm going to do that. And I know two of them, Jonathan Bushman in Oklahoma and Alex Summers in Wisconsin, are actually the initial, picking up a community-owned health plan in their own community. Because we ended up in this space because my very strong conclusion is you have to control the dollars if you want to control the system. And I haven't seen any dysfunction in healthcare that is an accident. It's all codified in these legal documents we call health plans. They don't provide any care, but they govern everything. And so that's why, basically our theory of change was if we could prove thousands of times in all these different settings that we could do it, we would then open source all these. We invested about $4 million in rewriting all these legal documents and then the data infrastructure to be able to ingest claims and stuff like this, the things you have to do to succeed here. So that's now open source. Anybody can get that. It's very wonky stuff. And we're doing stuff to make that more accessible. But we're trying to move any barrier, any excuse to do this. And it's a really big lever once you control the dollars.
Absolutely. And I think, my other questions and some of the things that I'm seeing are, how are you finding the people to connect? And like once you start having that conversation, once you start hearing those frustrations, where are the places that we can get people aligned or connected to some of the answers that you guys have come up with? And I see Larry Bauer said, Rosetta Fest, which I know we've talked about on here, these calls are great places for people to come once they've hit that point of frustration and we have some answers. But where have you seen, whether it's employers, businesses, benefits advisor, natural allies, people who are just tired of the money waste, like coming together?
Yeah, it's a great question. The good news in air quotes is it's rough out there as an employer. It's been rough for a while, but it's really bad this year. And it's interesting just how different, even just in the last year, the frustration level is. Obviously, it's happened with the ACA subsidies has brought additional light to this, and I think we're seeing in a lot of areas of our society, people going, wait, like, we've been band-aiding this thing. We got to do a rethink and a reset. And I would say that in terms of who are allies beyond the advisors in our program and DPC docs, I would put it into one kind of a general non-industry specific category of during COVID. Remember that term essential workers? Um, the companies that have employed essential workers. First responders, manufacturing, logistics, hospitality, farming. Generally, they are low margin organizations, public sector too, right? They have finite dollars, and this so-called solution of, hey, let's just jack deductibles and copays and all this stuff as our way of controlling cost. It didn't control any cost. It just put it onto the back of Americans who couldn't afford it. And so therefore we have 100 million Americans in debt to healthcare. And so if you look at the preponderance of the types of companies that are, we give out these awards for the best health plans in America, and we call the Rosies. It's those types of companies. And then to put a little finer point on it, I would say there's kind of four categories of um, employers. Mention one, public sector, right? They're very constrained budget wise. Now, historically, a lot of them kind of been asleep at the wheel. It's not their money. And, they've been told, by the status quo, you can't do anything about it. But they're like, oh my God, we got to do something about it. And, they're in a desperate situation. So public sector, great opportunity. I mentioned one, provider organizations, right? Sur Surgical hospital, community hospital, a multi-specialty group, a radiology group. They're all employers. And I needle my doc friends who are, they're complaining to me about, this big carrier, that big carrier, and for good reason. And I'm like, hey, what do you offer your employees for their health plan? And they're like, same company. I was like, well, do you see a disconnect? Um, and again, they've been told they're too small to do something. We started doing this when we were 5 employees. We like to get it below 5 employees, but that's not exactly Walmart. So that's a wonderful opportunity. They're very frustrated. And they're key allies, and it's a really powerful story when you can say, "Wouldn't you like the same plan your doctor has?" Um, Bucket three, nonprofit. United Way, right? Often as a meaningful size employer. And, if you look at the nonprofit community, people have often taken a career where they're relatively making less money than they could if they went into the public sector. And then they have largely crappy benefits, to be blunt. And they're again budget constrained, and they're credible in their community. One of the uh, community health plans is just getting going that I'm really excited about is a tiny home community, and they have retail stores to help them raise money. So the nonprofits are really a good one. And finally, cooperatives. And they are general, credit unions, grocery cooperatives. They generally care more about their employees and their community than others. And sorry for the long question, but it's like such a passionate one, or a long answer. One of the things, as I studied social movements and successful, revolutions and so on, there's this figure, 3.5%, and that is the percentage of a population to tip a successful revolution. That is not that big of a number. You can break that down into any given community, and that's a doable number of employers as a starting point. Again, we have this accident of history of employer-based healthcare. Some would say it's one of the original sins of our healthcare system, but it's there. 80 years later, it's there. Why not make it the source of redemption? And that's what we're seeing. And if you look at our long arc, the vision, what I'm going to talk about in my book is, I believe, if you look around the world, the best health ecosystems have, I've given a name, community-owned health plans, but I think it is a cooperatively owned health plan utility, and it's managed at the district scale. Water, fire, school, congressional district, like 25,000 to 750,000 seems to be the right number. That's a whole other rabbit hole I could go down. But those are some of the categories that are really compelling. And you get just the cooperative sector and ESOPs, and employee stock owned plans. That's 3.5% of the economy right there. these are organizations already predisposed.
Thank you. Like that really did. It helped me so much. I've worked in the manufacturing world, like
Yeah.
all of the things that you were saying, like it helps me to see that connect because you're talking about people who, or businesses where they don't have big margins. And so, especially when you look at something that's so necessary because you need a healthy workforce, you can't just retrain all the time. You need the people that you have showing up every day. So, health becomes such a critical point, but then you're sinking so much of your margin costs into something that it doesn't have to be. You and I could talk about this forever
Yeah,
because now
yeah.
I'm in the nonprofit world. But I wanted to see, Margaret, are you there? Did you want to come off mute and actually ask your question? Because I think you had a few layers and parts to it, about the South Central Foundation, and taking their model over. Go ahead.
Yes, sure. Yeah, I've been familiar with them. I've heard about them, I think a decade ago, and I think it's a fascinating model. And I know that the foundation offers assistance to other communities, I believe, in order to replicate the model. And I'm curious how much you know about that and whether they've been successful in helping other communities implement a similar model, that this idea of community self-determination
Yes,
in
yes.
particular.
And I'm going to put, I mentioned the stories on some of the organizations I mentioned here, including the South Central Foundation. So there's some more detail in there. And they absolutely do help other communities, in fact, from all over the world. Um, and it's been interesting though. I think they have been, if you look at who's adopted their model probably the best, it's been Singapore. Singapore did not have that great a primary care model before, and they've really adopted that. I mean, they're just very systematic. A lot of folks have tried to do it in the US without tackling the health plan part, and I think that's one of the areas where you're really pushing a boulder up the hill. If you're trying to tackle it without actually controlling the dollars, and just like a few extra dollars for primary care doesn't cut it. It's really, a rethink there. Um, I know Cherokee Nation, another Native American community has done that. They do that. In fact, if you go to uh, SCF NUCA,
Mhm.
NUKA for
Yeah.
South Central Foundation. I think it's .com and click on events. There's literally a thing going on this week. It's a virtual that they have training available. And then later in June, they have a full week long program. So they really have invested a lot to share their model.
Yeah.
And then just a shameless plug. I've got April Kyle on their CEO on my podcast that will publish in the next month or so.
Okay. Because I want to pick up on that link that you made between the community self-determination and the health plan, because
Yes.
that's really bringing together NUCA and Health Rosetta. It's really
Yes.
part of the key to being successful.
And we, if you're not a indigenous community, you don't have that same Indian Self-Determination Act. But what I have been writing about is I think there's two flavors of the Community Self-Determination Act. That's my name for what I think we need here. There's the self-proclaimed, where it's just communities like, damn the torpedoes, we're going to do it, and we're going to start figuring it out. And they've started with employers because it's easier there. But the other would be legislative. And if you look at, I shared a link earlier, I think before some folks jumped on, and you can reshare it. I wrote a two-part piece that published in the last week on Wendell Potter's Substack about rural electric cooperatives and how a century ago, uh, rural America was not electrified. Cities electrified. And there were these plucky farmers in Iowa and Minnesota and California and Washington State that, like, folks in Iowa, they put up power lines before they even knew what the power source was going to be. But what they did was they proved out the model so that when the window opened in the 30s, we're in the depression, and obviously trying to put people to work and address these issues. There was an executive order And then a year later, legislation that supported the electrification of rural America. And I think of our community health plans are that same thing. It's not all, they're not all perfect. They've been done by hook or crook, and we're not being overly prescriptive right now. On some we're helping out on building several of them, but we're not like being all judgmental if people aren't doing exactly our way, because like we need that innovation. And then we think we can take that learning if at a state level or a federal level they want to pick this up, because I think many of us believe it's very evident we're going through a rolling system collapse right now. It's probably being accelerated by some of the current activities, but you could argue it's already been happening in rural America. You can make that point, but I think it's pretty evident. And we have 100 million Americans in debt, and we have horrible outcomes the way we do. To me, that's already a collapsing system. The question is what will replace it. Could be worse, or we could do something better, and obviously that's what we want to do. And so we're doing the best we can with the resources we have, but we need a lot more, and we need a lot more people raising their hand and innovating. And initially, these have come out of benefit people starting this. Now this one in South Carolina that I alluded to, starting with a tiny home community as an employer, and starting with really the maternal journey. Probably many of you know it's a national embarrassment what our outcomes are when it comes to maternal and infant mortality amongst developed nations. And then it's like 3 or 4 times worse for people of color. And many of us think that's actually a nice Archimedes lever within the healthcare transformation. And so that started with the NGO, not benefits professionals. So I'm excited to see how that develops. And then hopefully we'll have many others starting in other realms, because, we haven't figured it all out by any means.
Thank you so much, Margaret, for coming on and sharing. And thank you, Dave, for, all your knowledge and sharing tonight. I'm going to pass it over to Michael. While I do that, I just want to make sure that I highlight for people quickly, this is recorded, and all of our past PC4AA Zoom meetings are also on our YouTube channel. So I'm sure Michael will mention it, but a number of the different people actually that Dave has mentioned, we've done these Zoom calls with. We've talked about the crisis in maternal health as well. And so just a lot of great information there, and that's right on our YouTube channel. But Michael, I'll let you tell more about what's going on with PC4AA.
Thanks, Patty. And thanks, Dave, for being with us tonight and for doing what you're doing around the country, for sort of bringing new leadership and new enthusiasm to what is solvable. We have a healthcare extraction system, not a healthcare system. And the opportunity is to build that healthcare system from the ground up, and to give communities what they need to figure out how to do this for themselves. That's what we're about. That's what you guys are about. And that's why this collaboration has been so rich over the years. Communities really can transform themselves by making primary care the foundation of healthcare, because primary care, as we know, is incredibly affordable. And when you do that, you start building your own healthcare system for yourself, by yourself, for, by, and of the community, instead of waiting for big government or some venture capital firm to come and claim to rescue you and then steal more of your money in the process, which is what happens over and over again. So to all of us on the call, please don't wait for an act of Congress. Get started. Call a friend. Have them over for a cup of coffee. Plot and plan. Figure out who you'll invite to the second meeting, then have the second meeting. Figure out who you're going to invite to your third meeting, and then start fixing things. And we'll help. We have a bunch of experienced organizers, a number of whom are on this call tonight, who will be with you shoulder to shoulder, helping you along the way. We have a local playbook. We have experience. We even can support local organizers when they first get started. So whether you're in Hershey, Pennsylvania, or in Bellingham, Washington, sit down and get started, and let us help any way we can. Just drop me an email if you need help, or you need support, or you want us to help you with a local organizer. My email is in the chat. Um, and just get started. There's Waiting isn't going to get anybody anyplace. When we get started, we can start rolling. And let me tell you, some of the amazing work groups we're seeing around the country are just doing tremendous things, and bring tremendous excitement and hope to what's sometimes a kind of difficult time. Anyway, now I'd like to introduce the amazing Lindsay Lopez, our social media lead, who's going to talk about how you can help us with the social media part of Primary Care for All Americans, as well as help support our Valentine's Day fundraiser. Lindsay.
Hi, everyone. So before we wrap up, I just wanted to share one quick thing, as Michael had mentioned. If you're not already following us on social media, please do so. It really helps us grow this important movement and connect us with people we might not otherwise reach. Every like, comment, share, or tag helps us spread the word about what's happening on the ground from our local work groups in places like Central Falls, New Bedford, Richmond, Queens, and many more, to primary care stories and developments across the country and moments like this where community voices come together to spark change. And just like our YouTube, we post clips on all our socials, LinkedIn, Instagram, and Facebook, of Zoom sessions like this one. So if you haven't been to one before, or you just want to rewatch something, you can always check those places out. And since Valentine's Day is coming up, we're inviting you guys to be our Valentine by making a donation. Your support helps fuel this work, organizing locally, amplifying primary care voices, and pushing for a healthcare system that's more fair, more human, and of course, rooted in community. If you believe in primary care for all Americans, following, sharing, and donating are all powerful ways to show that love this season. And I'll drop our social handles and the donation link in the chat below, and just want to say thank you guys for being here and being a part of this with us.
Thank you so much, Lindsay. Thank you all for joining us tonight. In 1 month, we'll be meeting again. So we encourage everyone to invite someone new, get involved, join the movement. Mark your calendars. It is Thursday, March 12th, which is a different night for us. We will be hearing from Dr. Kevin Grumbach, who will be talking about universal unified funding of primary care for all. You can register on our website, www.primarycareforallamericans.org, where you can also check out our local and state playbook, volunteer, donate, support the cause, get involved. Thank you again so much, Dave, for coming out, to all of our facilitators and hosts. And thank you to everyone for joining us tonight. Have a great evening.